Hello, my name is Kunal Mishra, and I'm an internal medicine resident at Texas Tech El Paso. On behalf of my co-authors, I would like to present a fascinating and unique case on definite very late in-stent thrombosis causing STEMI. Our case involves a 51-year-old male who is an active smoker with a past medical history of an LAD stent placement 10 years ago, chronic controlled AFib on therapeutic anticoagulation with warfarin, who presented with an episode of typical chest pain. The initial EKG shown here indicated that he had an acute inferior posterior STEMI. Based on this patient was taken for an emergent cath, which showed that he had an occlusion at the proximal RCA, as indicated by the red arrow on the left picture. This was treated with a drug-eluting stent with optimal results. Notably, as we can see in the right picture, his 10-year-old LAD stent was still patent. Following the placement of a drug-eluting stent in the RCA, this patient was placed on dual antiplatelet therapy. An echo was done which showed he had an EF of 30%. While remaining in the CCU, he developed another episode of chest pain 2 days later, with repeat coronary angiography showing patent RCA and LAD stents shown here. Soon after this, patient developed an episode of hemotemesis. However, due to the fact that hemoglobin was stable and there were no signs of hemodynamic compromise, DAPT therapy and warfarin were continued. An emergent EGD indicated gastritis that did not require intervention. 4 days following this episode, this patient experienced another episode of chest pain with EKG this time showing an acute anteroseptal STEMI shown here. This episode then led to a repeat emergent angiogram, with the results now revealing a definite very late in-stent thrombosis of the LAD indicated by the red arrow on the left picture, which, as you may remember, was widely patent just a few days ago. This was treated with drug-eluting stent placement with optimal results. Following the finding of late in-stent thrombosis, a clopidogrel response assay was done, which showed normal P2Y12 receptor blockade. Additionally, patient had a hypercoagulable workup which returned negative. Triple therapy was subsequently escalated to include ticagrelor 90 mg BID, 81 mg of aspirin QD, and apixaban 5 mg BID. Patient was actively counseled at discharge on smoking cessation and has remained tobacco-free. As we know, the incidence of very late stent thrombosis following drug-eluting stent is very rare, with 5 events per 1,000 DES per a recent meta-analysis. Risk factors that have been correlated with ST include but are not limited to GI bleeds, ACS, low EF, and smoking, all of which this patient had. This case showcases that while the incidence of late stent thrombosis following DES placement is very low, what's even more rare is the finding of a late stent thrombosis in a controlled environment such as a CCU. As I mentioned before, the majority of patients' clinical course occurred while he was in a controlled setting, where he was getting optimal therapy, no issues with compliance, and he was being monitored very closely. Despite all of this, this patient still had a very late stent thrombosis in a 10-year-old LAD stent, which goes to prove the fact that if it's supposed to happen, it will happen. This case also illustrates the importance of these risk factors, as they most likely predispose the patient for this unusual sequence of events. I am happy to report, though, that with close outpatient follow-up, smoking cessation, and continued compliance, this patient has not had any further events. Thank you for your time.